Welcome to our live sports medicine webinar. Thank you for joining us. My name is Jacob and I'll be the facilitator for the presentation today. Before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. At any time, you may adjust your audio using any computer volume settings that you may have. During the presentation, you will see multiple choice polling questions. To participate in the polls, please ensure you are not in full screen mode. Then simply select the button to the left of the answer that best represents your views or experiences. On the right-hand side of the screen, you will see the Q&A window. To send a question, click in the text box and type your text, and when finished, click the send button or press enter. All questions you submit are only seen by today's presenters, and your questions will be responded to in the order in which they were received, will be addressed throughout and at the end of the presentation. We are joined today by our speakers, Dr. Michael Alea, Dr. Guillaume Gonzalez-Lomas, Dr. Les Jazwari, Dr. Mehul Shah, and Dr. Eric Strauss. This time I would like to turn the microphone over to Dr. Alea to begin the presentation.
Hi, my name is Dr. Mike Alea. I'm here from NYU Langone Orthopedic Hospital, and I'd like to welcome everybody for joining us today. This is the first of a series of hopefully many CMEs that we're doing here at NYU Langone. And this one is really dedicated to sports medicine, and it's called the Management of Meniscal Pathology from Partial Meniscectomy to Transplantation. I would like to introduce our speakers. The first talk is going to be from Dr. Guillaume Gonzalez-Lomas, which is going to talk about meniscus preservation strategies from resection to repair. We're going to talk about extending the indications for meniscus repair and orthobiologics in terms of meniscus replacement, and that's going to be by Dr. Les Jazwari. Then we're going to switch gears a little bit and have a talk from Dr. Eric Strauss looking at meniscus allograft transplantations in terms of indications, techniques, and results. And then myself and Dr. Mehul Shah, who's co-moderating this with me, we're going to speak about certain case presentations and how our panel would manage these difficult patients and hopefully take some polls and questions from the crowd. So again, I'd like to welcome everybody today and thank you for joining. And now we're going to turn it over to Dr. Guillaume Gonzalez-Lomas to talk about meniscus preservation strategies.
Okay, thanks a lot, Mike. I think this is a great topic to start off with. Meniscus or partial meniscectomies are still the most common CPT code orthopedic surgeons use. I think we've all kind of memorized the 29880s, 29881s, and it's for good reason. The pathology is ubiquitous, and the good news is that we've kind of known how to do one thing, which is resect, for a long time, and as time has gone on, we've gotten a little bit better and more parsimonious in how much we took. And I think now we're getting to a point where we're actually really able to preserve meniscus and even potentially replace. And I think the different speakers are going to touch on all those points. So my task today is really to sort of take the audience through an algorithm for when a meniscus is better just resected if a tear, or when the indication calls for a repair. And I'll just talk about some specific strategies unique to some of the tear patterns that we encounter. So, I think there have been many biomechanical studies done at this point from every lab, internationally, that really show the devastating effects of even a partial meniscectomy on the cartilage, on the joint. And so the more meniscus you remove, you essentially increase the contact pressures on the remaining cartilage, and we know that there's a direct correlation between that and the development of arthritis later on. And so ultimately, I think all of us, in the back of our minds, no matter what case we're doing, and really no matter what age or function the patient is at, our goal is to try to preserve as much meniscus as possible. But of course, the question is, what's the quality of that tissue? And does it make sense to preserve it, or are we setting the patient up for failure? We also know from previous studies that the majority of the vasculature, the majority of the healing potential of the meniscus really lies in that peripheral 1/3. And we have also kind of, I think in all of our minds, we've had this image of meniscus structure that includes these circumferential fibers that really are the key ones. but I think that some of our understanding is being advanced, and there are a couple of labs that have been looking at more detailed infrastructure of the meniscus, and they found these tie fibers. And what these things are is they're essentially kind of scaffolding that's even between the circumferential fibers. And they tend to house small blood vessels, so that's obviously critical in healing. But they also themselves are structurally quite resilient. And so this may be a reason why some tears previously thought irreparable, for example, radial tears, may actually have a chance to heal and may actually be able to resist suture pullout. And it also is going to be important in the manufacturing of meniscus scaffolds, so collagen scaffolds, and really trying to replicate that meniscus structure. So I think this is an exciting time in the world of understanding meniscus infrastructure and microstructure. All right, so in terms of meniscus preservation strategies, what I look at when I'm faced with a knee with a meniscus tear is first of all, how am I going to optimize my visualization? And I think this has been popularized a little bit more in the last 4 to 5 years, but a partial MCL release should really be part of every surgeon's armamentarium. It's easy to do, and I'll go through some of the studies that show its lack of morbidity. So I always have that in the back of my mind and am ready to pursue that if that medial compartment cannot be opened. I'm always thinking about repair versus resection indications. If I repair, I'm going to be considering marrow venting. And then we're also going to talk about unique meniscus tear patterns and sort of what to be thinking in each of those cases. So the other important thing is, of course, the patient. We don't treat MRIs, we treat humans. So what are their expectations? And some patients will tell you straight up that they just want to get back on their feet as soon as possible. Maybe they work in construction, maybe they're just impatient, but they don't want to go through any kind of long rehab. So it's important to get that out in the open right away. Secondly, what kind of rehab are they able to comply with? Is this someone who is a professional athlete, a college athlete? Or are they someone who maybe is not very active to begin with? So you want to factor these in. And then, of course, once you get into the knee, what's the tissue quality? Is this going to hold stitches? Are they just going to pull through? I think for a large number of us, this still kind of remains in the realm of the subjective. We talk about the meniscus taper centrally and how that denotes, possibly more robust tissue and a meniscus that has not been through the shredder. But the reality is that we still really don't have very firm algorithm that allows us to say, hey, this meniscus is garbage just by looking at it versus one that's repairable. And so I think you really have to treat each case individually and probe it and just get a sense of the mechanics. Finally, is that repair technically feasible? So are you going to be able to do it? Are you going to be able to access it with the tools that you have? So the other important component of this is to have all the tools that you might potentially need at your disposal. And that means that a meniscectomy is not just, that throwaway case at the end of the day, but one where you have everything that you potentially need. And some of the other speakers later on today will talk about biologics and collagen implants. And so all of these are questions you want to ask yourself before starting the surgery. And then obviously, if there are any concomitant injuries, you're going to want to plan the order of surgery if you're doing an ACL. And you're also going to want to make sure that you optimize that biomechanical environment if you're deciding to repair. And that may mean an osteotomy if a patient is in significant varus. Okay, so the partial MCL release is, you can do this pretty much at any point along the MCL, proximally or distally. And there have been a few studies now that have shown that patients do actually quite well with this. And there may be actually some sort of pain relieving component to it in patients with some mild arthritis. The main point is you really just want to release that posterior MCL. You don't want to release the superficial MCL anteriorly. You can't actually destabilize the joint if you completely transect the MCL. In this study here out of Turkey, they found that the medial joint space increased by about 2 millimeters. So, that's not an unstable knee. That's not a knee opening 5 to 10 millimeters. So that's a patient who's going to do fine and not even feel unstable postoperatively. And what you do is you take an 18-gauge spinal needle and you just go kind of right in this area here, and you put the spinal needle, and it feels almost like Rice Krispies. The sweet spot is this crunchy area, and within 1 or 2 stabs, you can just start to feel a little bit of release of the MCL if you have the knee in some valgus stress. And you can really control how much you need to open. And we'll go over some cases where I did that. And in this particular study, they actually found that the medial joint space reverted back to its baseline by 6 months. So it actually kind of reconstituted. And these patients did very well clinically. So I think this is something that is worth considering if you're ever in a situation where you can't really access that medial compartment that well. Here's another study, and I didn't just pick this because the first author has the same name as I do, but meniscectomy plus MCL pie crusting versus no pie crusting, and they found that the patients who had the partial MCL release, the pie crusting, had a better lysosome, less pain at 6 months, they had no persistent medial pain, and they had decreased cartilage iatrogenic injury. Okay, so let's talk a little bit about meniscectomy. So here I've got a 44-year-old male. He's got pain immediately. This guy had already undergone a partial medial meniscectomy, and he had persistent pain. So, we look at his mechanical axis views, and you can see that on the left side, which is his symptomatic side, he is in a little bit of varus. So this may be a question of just, varus knee, and he had his meniscectomy, and so be it, do an HTO, not too much arthritis there. Play the video. And so in this case, you can see that that medial meniscus, it definitely looks like it's still torn. And so this is a little bit odd because you say, well, this guy underwent a partial meniscectomy. So let's go back to the slide deck here. Here's a sagittal, and same sort of thing. You can see that, it doesn't really look like a lot of meniscus was removed. Okay, so you go in here, and the first thing that you see is you can't really see the posterior horn. So we're in the medial compartment, and we can't really access that. I do see potentially a little bit of chondral damage. And we do a partial MCL release, and all of a sudden that posterior horn really kind of comes into full view. And you can tell that it's possible that a partial meniscectomy was not conducted fully because that posterior horn, could not be visualized. And if we play the video here, you can see that, you really get access, and you can open that more if you need to even, but you really get access to, in this case, perform a thorough partial meniscectomy. And so that could make a significant difference. Okay, go back to the slide deck. So here's a meniscectomy. So obviously we never like to see, less meniscus. But in this particular case, this patient's doing great. So no HTO, and he may need one in the future, but not right now. In terms of meniscus repair, I think most of us are familiar with the classic indications, about a centimeter tear. You want to have that peripherally, stable knee. And it used to really be younger patients, but I think we're finding now that older patients do well. Here's a study out of Stedman Philippon group, and they found no difference between under 40 and 40 and over 40 at a 16-year follow-up. So that's pretty impressive follow-up, only a 5% failure rate. And if you can play the video here, I think this is sort of a standard way that a lot of us going to do a kind of a classic bucket handle meniscus. And so, we're going to try to RAS, make sure we get that kind of nice bleeding tissue peripherally. And then there's a lot of ways to skin a cat. Inside out is tried and true and still the gold standard. I think if the tear is more posterior, you can try some of these all-inside devices. The outcome studies are pretty much equivocal. They essentially say that both techniques yield similar results. In some cases, you may want to do outside in. And so, in the end, you have kind of a nice stable repair. And I think the key here is to not just put a couple stitches and hope and pray that, the lightest breeze doesn't blow on the meniscus. You really want to make sure that this is sturdy. Go back to the slide deck. So let's take a look at some specific tears. So here's a 15-year-old, and he's got this kind of intersubstance tear, as you can see in the red circles, as a lateral meniscus. Play the video. And so you can see that, this tear is a little bit hidden. This kid has had 3 or 4 episodes of knee locking, and then it kind of gets better, and he goes back to playing basketball, and then it locks again. But there's something that's definitely a little bit off. Play the video again. So in this particular case, we knew from the MRI that there was some intersubstance signal. So we just took out a little bit of that central component, that central meniscal taper component, and sure enough, it revealed this intersubstance tear. And so this is at the end of the repair, and what we did is we put some barrel sutures using a device. There's a couple of these that are out there where you can actually put the suture all within the joint. You don't have to have any PEEK or biocomposite pods. And so you don't have to suture it to the capsule. You can actually suture the meniscus to itself. And so in this case, we put a couple of barrel sutures through the body, and then this is the last suture, which we're doing sort of in a vertical mattress configuration. And so, that is, I think, an option that we have now that's new, and it allows us to be a little bit more creative. Now, in this case, I also added some marrow venting, and I think if you're not doing a concomitant ACL injury or other, ligamentous reconstruction, and the knee is not going to be bathed in that nice marrow venting is the way to go. Go back to the slide deck, please. So this has actually been looked at by Laprad's group, and they've actually found that marrow venting is the equivalent of doing a meniscus repair with an ACL reconstruction. So that's pretty impressive, but getting at least 4 or 5 holes, you can do that in that lateral aspect of the notch, which is where the ACL lives, it seems to really potentiate healing. So that is, if you're going to repair, I think marrow venting is an additional step that you want to include. What about radial tears? So, and you can play the video here. So classically, these tears were seen as irreparable. We really couldn't do anything with them. Now, every radial tear is not the same. So I look at this tear, and what I see is really more of a complex tear. I see it's going to be potentially hard to put, sutures and really bring 2 distinct sides together. So, this is a tear where, I had a long conversation with the patient, and this, we'll talk about this later on. I think Laith is talking about collagen implants. This might be a perfect case for something like a collagen meniscus implant. But in this particular case, the patient really wanted, you can go back to the slide deck, the patient really wanted to get back as early as possible. And so, we do a fairly significant meniscectomy. So, none of us want to see this. I mean, this is a pretty significant amount of meniscus that's removed. But again, every patient's different, and some patients just want to get back, and they're, you can educate them about the risks of them developing arthritis 10 or 15 years down the road. But, for many of them too, there are patients with subtotal or complete meniscectomies that go on to not have arthritis. So, there's something else at work here. Obviously, there's a genetic predisposition that's probably a factor as well. But at any rate, this patient was happy to, be able to go back to his activities fairly quickly. Here's another patient. This guy's actually older than our last patient, but you look at his knee and really not a trace of arthritis in any of the compartments, and he's got a medial radial tear as well. So if we can play the video here, to me this tear is a little bit different. This looks more like more robust tissue. He still has that preserved meniscal taper. This was also an acute injury. The patient felt something go, a pop in the knee, and then he had pain. So this to me is something repairable, and even if the patient is 50, I am going to consider trying to fix this. So we can go back to the slide deck and then just play the next video. What I like to do in these cases is we know that central tissue really has very poor blood supply. So I actually resect that. And then, yeah, exactly. When we go to the video here, we can use the device, one of the devices that I mentioned before, that all-inside device, and do these side-to-side sutures. And in this case, we did 3 of them. Go back to the slide deck. And so we pass that, and so we really get this is the last suture that we're putting in, and then we tie it up. This patient did very well. So a case like this, you do have to protect. So he's got to be willing to go 6 weeks on crutches, of course. Okay. All right, so meniscus root repairs. This is a whole entity unto itself, and I'll just summarize it by saying that, again, we know that these are essentially tantamount to having a subtotal meniscectomy because you lose the tension of the circumferential fibers. We've got this this kind of newer interest in them because I think we're better at fixing them now, and it seems like up to 9 millimeters from the root, that is still considered a root tear. So you can fix those as you would a root. The important concept here is to not over-tension, not to try to, if that tear is 9 millimeters from the actual root, don't bring the end all the way back to the root. You will over-tension it. But you still want to essentially have, restore the tension that it's got. And so that in situ repair seems to restore the load to baseline. And I would say this is one of the typical ways that we do it. There are ways to do these with suture anchors, but this transosseous technique is fairly common. I would say a word of caution, and this paper is out of our group here at NYU, and really what it showed is that these are patients with root tears who underwent a root repair, and clinically they did well, but they actually had a deterioration in their arthritis. And I think one important point is, if you look here, this is the same patient before and after. So here's the root tear, here is the repair, and if you look at the another image, you can see that this is pre-op, and the meniscus is extruded, and if you look at post-op, the meniscus is even more extruded, and there seems to be more cartilage loss. So really no correlation between that, fixing the root and preventing any kind of cartilage loss. I think one interesting point here is that it may be that once the meniscus is extruded, you've really lost the ability to bring that back. At that point, the knee has kind of, the capsule even has probably lost some integrity. So at that point, the horse might be out of the barn. So here's a root tear example, and if you can just play the video, we're just passing the last stitch here, and then we're going to shuttle that, and then we can tie that over a button on the tibia. Okay, go back to the deck, please. All right, so I'll just finish with these meniscus ramp lesions, and really the take-home point for these is, I don't think we know the clinical significance of them yet. We just know that they happen. So up to 16% of patients undergoing ACL reconstruction have been shown to have them. MRI is not very good at detecting them. It seems to be because MRIs are typically done with the knee in extension, and that might push that posterior tissue together. So perhaps an MRI and a little bit of flexion might denote more of them. We really don't know what their biomechanical role are, but even though non-operative treatment works, there may be some cases where these render the meniscus loose, And if you could just play this video, this is the last one. This is one of our colleagues, Rob Meislin, fixing one. So he's looking in the back here, and so the meniscus is on the left of your screen, and the capsule is on the right as a posterior horn, and he's basically passing the sutures there, and then he's going to tie those. Okay, you can go back to the slide deck. So just to summarize, really think about that MCL release. I think all of us use it periodically. I think what's still kind of left for us to figure out is if doing that to the LCL has the same effect with just as low morbidity. I'm a little more hesitant to do that because of the posterolateral corner, but I think that bears some investigation. And really, individualize that surgery, have all your tools at your disposal for every case, because you never know when you might change your mind, as long as you've spoken to the patient about every possible permutation of their rehab, and then consider that marrow venting if you decide to repair. Okay, thanks a lot.
All right. Thanks, Guillaume. This is Mehul Shah, the co-moderator for the talk. That was a great talk for our listeners. Again, we would encourage any type of questions. So again, as you can see, there's an area in which you can type in questions, and we will answer them. We would love for this to be if you guys participate as much as you'd like. So for our next talk, it's going to be our section chief, Laith Jazraoui, and he's talking about extending the indications for meniscus repair and orthobiologics for meniscal replacement. Laith?
All right, thanks, Mehul. So I thought that was an excellent introduction to the topic on meniscus repair. There may be some overlap, and I'll try to go quickly through that as I go through my talk. There's really no pertinent disclosures. So the concept of extending the indications for meniscus repair, or whether we contemplate meniscus transplant, replacement, or augmentation. So you get a case like this, and this is certainly not part of this talk. This is a person more with arthritis. Yeah, he's got a meniscus tear. He may even have a meniscus root, but this is something that we're probably not considering enhancing or even trying to fix this meniscus. So what I'm going to try to go through is, I'm going to go quickly through some of the meniscus repair stuff. Guillaume hit on most of it, but I'm really going to focus on those hypovascular, or what we consider the unrepairable tear. So those are these traditional radial, which Guillaume got into, some of these horizontal meniscus tears, these cleavage tears that we talked about, these really bad bucket handles. Guillaume got into the root avulsions, and we'll go into some complex flap tears that now we're considering fixing with some of the new devices. Then we'll get into whether PRP, fibrin clot, or even some of the stem cells that are out there now will aid us in getting this meniscus to heal. We'll also get into meniscus scaffolds and segmental grafts and see what's currently available for us and whether these actually work. So our first question is a 20-year-old with an ACL tear one year ago, untreated bucket handle meniscus. So what would you do here? Would you resect it, fix it, or repair it? And I think I see about 100%, or one person so far said resection to a stable base. But the concept is, are we going to fix this? And certainly, if you look at what I chose here, we can take the polling down and move forward to keep on time. So we're getting some of the numbers out. So it seems like most people want to resect. So the idea is, well, if we're going to resect it, that's easy. But if we want to fix it, what we're going to do. And in this case, because there was also an ACL, again, concomitant ACL reconstruction can enhance the healing of these meniscus tears, and when you do repair. So certainly I chose an inside-out repair on this to really maximize my healing. So Guillaume got into this with the meniscectomy, and certainly the bottom line is this. If you're going to do a meniscectomy on a patient, if you look at the overall rate of OA, it's certainly going to progress. The incidence of OA is much greater for partial lateral meniscectomy than medial meniscectomy, and there's definitely a correlation between how much you remove and the amount of arthritis that they get. So when we look at the outcomes of repair versus partial meniscectomy, again, repairs, 22% incidence of OA versus a much higher incidence in resection, where you're looking at about a 36% incidence of OA at follow-up with partial medial meniscectomies. So what about those hypovascular tears? And I think this is the sort of the central part of my talk. How do we get these things to enhance? So when you looked at this study by Feng et al., he looked at second look arthroscopic evaluation of bucket handle tears with ACL reconstructions. These included both red, white, and complex tears as well, and 82% were completely healed. Now, I understand that there's an ACL reconstruction that was done concomitantly, but the fact remains that there is a potential, even in the non-vascular zone, for these to heal. And the concept that, well, why does an ACL reconstruction enhance this potential healing? And that's when we're going to get into these potential marrow elements aiding in healing this. So what about white meniscus repairs? Galatcher looked at this, and he had 87 patients, no ACL injuries, young patients, and all of these tears were in the white area, and they were isolated lesions. So he had a 68% success rate. Now, that's still a 32% failure rate, but the bottom line is that this is historically what we would consider tears that we would never, consider fixing. So the concept of getting a 68% healing rate is something that at least piques my interest in saying, well, maybe we don't understand everything about this, and maybe with the right devices we can, increase the indications, for fixing these white zone tears. Next slide, please. I got that. So, Guillaume touched on this, these complete radial tears, and I think this is the concept of getting into, well, when do we use fibrin clot? And I think this is always difficult, and certainly for these radial tears with these newer devices that Guillaume presented as well, where you're able to, put these side-to-side stitches very easily. The concept of, yes, they can heal, and historically the fibrin clot came and went, difficulty in making it, a time-consuming in the OR, but the concept is, well, if we can get these tears to heal now with these newer fixator devices, well, maybe we can start enhancing these indications and using fibrin clot again. And I'm going to get into PRP and some of the stem cell data that we have on this. What about horizontal meniscus tears? Again, typically considered a tear that we would not repair. These are considered hypovascular tears that extend from the white zone, generally all the way back to the red zone. And if you looked at some of the early data on this, did not report, good results. With some of the newer devices, and really when you look closely at the literature, and when you look at Kurzweil's review, he showed a couple of things. Certainly that 98 repairs of horizontal tears were evaluated in these slides, in these studies. And reoperation was the criteria for treatment failure. And really what he saw, that there was a 77% success rate. So I found that, pretty impressive with this, and certainly helps us consider when we should increase the indication for fixing this. And certainly the device that Guillaume showed, which is a device that allows you to put in a horizontal a bail stitch, which is basically you're able to close the inferior and superior leaflet together very easily. And in this case, the device is a Ceterix device company that we utilize. It makes repair of these tears much easier. So here's a study out of Korea looking at horizontal meniscus cleavage tears with marrow stimulating techniques, and they looked at these patients at a follow-up of 45 months, and VA scores improved from 6.7 to 1.9, Lysholm 48 to 92, Tegner increased as well, and they looked at 11 patients with second look arthroscopy, and 8 showed complete healing, 2 had incomplete healing, and 1 had failed. So again, a tear that was traditionally had very poor healing rates. With some of these newer devices, as you can see in these pictures, better outcomes. So what about contact stresses? Well, certainly if you can get these things to heal and get them to heal whole, you're going to improve the contact stresses. And even in cases where you removed one of the leaves, there was still an increase in the contact stresses in the area. Again, not as bad as a double leaf resection, but the idea is that maybe keeping one leaf is certainly not as good as keeping both leaves. And it's the concept of considering that as a whole meniscus or a meniscus that's going to help with transition of stress, maybe not so good. So what about older patients? I'm not going to review this again. Guillaume touched on it. If you're an older patient, and there are a lot of us out there, you can get your meniscus fixed. It's okay, even if it extends potentially to the non-healing zone. So now that we know it's feasible and that we can fix these, how can we extend it? And I think the concept is that you should be comfortable with all these devices. I think most of us are comfortable with the first picture on the top left, these all-inside devices, but I really encourage everyone to get comfortable with inside-out repairs and to be able, and outside-in repairs, to be able to attack these menisci from all angles and really try to improve fixation stability, as Dr. Lomas had spoken about. So really, the gold standard is an inside-out suture, but some of these all-inside devices are gaining traction as well. So what are some of the complications? Well, certainly with these all-inside devices is vascular injury. I think this is rare, but it's certainly something to consider, especially when you're on the lateral side and going from the ipsilateral part of the knee towards the lateral meniscus, where the artery sits very close to this fixator device. But I think the most concerning problem with these all-inside devices is, and what we're beginning to see, and we can discuss this in the question and answer sessions, is these hypotubes, where they basically make a big hole, and when you're putting these devices through, you're sometimes going through a potential non-healing zone to get these devices. And I think that's where the concern is, that you're making these large holes that can essentially be tear propagators and cause new tears to occur. So Guillaume touched on this again. You need adequate visualization. Don't hesitate to pie crust the MCL. I tend to pie crust it off the tibia. I find it a lot easier with essentially one poke hole through the skin, and I'm able to sort of elevate it right off the proximal tibia. When I know I'm going to do a repair, I try to keep the leg holder as close to the kneecap as possible. This, again, allows me to put more significant stress on the knee to open up that side. And again, with tight lateral structures, I still haven't gone to pie crust in the LCL, but this is certainly something where you'll need a lot of stress to open up that side. But the concept of doing that as well is certainly, warrants some further research. So what about circumferential suturing? I think this is a game changer in terms of our approach to these radial tears. I think these radial tears historically have been very difficult and have been problematic in terms of getting to heal. This device, where you're able to put a master suture inside the knee, it's similar to an espresso device that we utilize in the shoulder to pass sutures through the cuff. I think you need to learn how to use this. It will certainly increase your ability to repair some of these complex tears. Here's another question. 17-year-old female soccer player, ACL tacked, this radial tear. Debride it, fix it, inside out, all inside suture repair, or an inside out suture repair. So these are often challenging. It depends on the amount of meniscus that's there. So there's about 20% of the meniscus. It looks like we're getting towards an all inside suture repair. I know the talks about extended indications, but certainly this is one where you can consider repair, I think. So you can go to the next slide, see what we did. So in this case, if you really probe the tear, you can see it went all the way back to the red zone and crossed all the way into the white zone. And typical for me is to sort of debride that inner margin and then put these side-to-side sutures in. Here's another one, radial flap tear. Again, you can see it here as I bring it up. Again, historically, something where I would probably resect it, and in this case, I decided to fix it again with this all-inside device, putting these bail stitches in. We're actually able to compress this in this young individual. And these are just some other pictures showing the device being deployed and then suture tying occurring. And then here's your sort of end result. Again, controversial. We can discuss this in the question and answer session, but this is certainly about increasing the indications to fixing these. And this is a 4-month second look where you can't even see the 2O sutures present there anymore. Here's another tear, another horizontal cleavage tear in a young patient. Again, someone would just resect that inferior leaflet as it looks the most degenerative. Again, this device can be very helpful in sort of deploying these bail stitches and then ending up with sort of that superior and inferior leaf close together. So again, back to this device, these radial tears, historically very difficult to deal with. certainly when you look at this biomechanical study, looking at putting these together, it certainly improves the contact stresses that are there, and looking at the type of sutures that are placed, these vertical suture configuration created by this all-inside device essentially resulted in lower displacement and higher loads of failure than the traditional inside-out technique. So these side-to-side stitches biomechanically work. So, okay, now we know it's technically feasible. We can, in terms of repairing this with some of these new devices. But can we make it better? How can we biologically enhance our repair? So we want to promote chemotaxis, cellular proliferation, matrix production. Stem cells, do they work? PRP, and then all these other elements that in terms of marrow stimulation and how we do it. So the question is, does it really work? So when you look at platelet-rich plasma, this was popular when it first came out, and if you look at this study, it's a level 3 study, but 15 repairs augmented with PRP, 20 without, basically no difference. So I think this paper and several others kind of confirm that PRP probably doesn't work in terms of enhancing meniscus repair. Well, what about stem cells? Well, there's not much out there, and certainly if you look at this is looking at meniscus repair with human chondrocytes seated in a mesh. And if you looked at this, certainly they showed in an animal model there's some improved healing. But certainly this is not ready for prime time, and there's going to be a lot of data coming out looking at whether stem cells could actually improve healing in meniscus repairs. So, and if you look at this one, this is some MSCs seated on a collagen scaffold that was then implanted in sheep. And certainly this is something to see if it was feasible. And in an animal model, it was certainly feasible. And then they did the first one into human and sewed it into the avascular zone. And it showed that, yes, you can do this, but the question is only 5 patients, and we're not really sure about whether this is going to, be long-term healer, whether this can heal or not. So what about the current scaffolds that we have that are available? And so the goal of these scaffolds is to replicate biomechanically and ultimately arthroprotect the native meniscus through tissue ingrowth. So we take out 50% of the meniscus. We want to replace that back to improve the contact stresses and prevent degenerative arthritis from occurring. These scaffolds, particularly the CMI that's available in the United States, initially with the name Menaflex, now marketed by Ivy Sports, came to the market. It has a challenging regulatory history, but it's certainly back. And the concept is suturing this bovine collagen into the native meniscus. And when you look at Rodkey's initial study, it was very interesting. But one thing that was clear through it, and I know this is a very busy slide, that if you look in the chronic group, so second to last line, then the patients who received an implant, they regained significantly more of their activity than control. So I think in the concept of patients who have these chronic tears that have an intact posterior and anterior root, that there may be a potential role if these patients are symptomatic in replacing some of their meniscus, assuming their alignment is okay and assuming they don't have any cartilage damage in addition to the meniscus. So there is a role for this. I think there's a small role, but it's certainly something to consider when dealing with these patients. When you look at, there are many studies out there looking at this. This was a systematic review looking at all types of resorbable collagen scaffolds, and certainly in the right patient, that chronic patient with persistent pain, normal alignment, no cartilage defects, that there may be a role in terms of using these scaffolds. The ActiFit device, not available in the United States, is a polyurethane scaffold as opposed to this collagen scaffold, with the potential benefit that there's better handling characteristics for this, that it's easier to suture. Well, the results have not been certainly so promising yet. There are certainly issues with implant extrusion and bone edema treated in several of these cases. So I think this is something that we don't have available, but it is certainly something that I think that's out there, and there are other devices that are to come out. But certainly this is not ready for prime time. And these are just some other issues shown with this polyurethane implant. Okay, so I think this is one of our last questions. 22-year-old lateral meniscus tear, also an ACL, this radial tear, posterior to the popliteus. One, would you excise that large flap? Would you do a root avulsion type repair? again, the question is whether it's 9 millimeters. Would you do a fixator repair, some type of either all-inside fast fix or the Ceterix device, or would you do an inside-out repair? Fixator repair versus all-inside sutures like the Ceterix device. So it's looking like some type of fixator repair with the fast fix. Okay, you can go to the next slide. Okay, so I think fixator repair 1. So in this case, I again use this sort of all-inside suturing device rather than use a fixator device, which is hard to get these radial type tears to get sort of anatomically fixed. So in summary, I think we should definitely be increasing our meniscus repairs beyond what we traditionally think are repairable tears, like our red-white or red-red vertical tears. So getting into that sort of more complex zone and really attacking these, and with better approach to the radial tears, I certainly think this is possible with our all-inside devices. These newer fixation techniques allow us to better repair these with stronger type of suture configurations that we can pass through there. PRP has no defined role at this point in terms of enhancing repair. Stem cells on bioactive scaffolds may have a role in the future. I think CMI, the collagen meniscus implant, has some limited efficacy, but certainly there's a role in chronic patients with a deficient meniscus with intact anterior and posterior horns with no alignment abnormalities and no cartilage abnormalities to get that device. Polyurethane meniscus scaffold, no role at this point. Xenograft material, shows some early promise, but really no role at this point. And novice meniscus replacements are actively being investigated, but certainly doesn't stand to the current meniscus transplant techniques with allograft that Eric's going to get into, as the results with those are pretty good. Thank you.
All right, Laith, thanks for that great talk. We do have some questions for the audience, and again, we do encourage these questions. So, Guillaume, this question seems to be for you, and they would like for you to discuss your management of bucket handle meniscus tears, particularly the chronic or subacute ones. What would you do for a chronic one that actually can be reduced, but you may know maybe a quite old one, or maybe one that has some plastic deformation that doesn't reduce completely what you like? So can you talk about your management in those two different scenarios?
Yeah, I think that's a great question. I mean, you sort of get in there sometimes with whether or not there's an ACL, and you're excited that you could potentially reduce this and repair it, and then especially in the chronic case, and I would say that 6 weeks, in my experience, is usually that threshold. After that, a lot of times, if the bucket, if the tear has remained in the notch, it can be quite difficult to reduce. So if you can't reduce it, that's easy. There's really not much to do at that point, and especially if they're having mechanical symptoms, you resect it. If you can reduce it, but it's not, it seems to be popping back. I do take these on a case-by-case basis. So one of the things you can do is, again, just look at the viability of the tissue. Do you have a residual meniscus taper, or does it just look like balled-up collagen? Is there a benefit to suturing just a bunch of collagen back there and hoping that, it acts as some kind of cushion? If the tear is, in my experience, if it is not staying where it wants to be without any kind of effort, you will not have a successful repair. I mean, you can make it look good at that moment, but it's essentially, a house on stilts, and the second there's any kind of biomechanical load on that will fail. So one of the options is you can resect some of it, and sometimes if you are able to get behind it and just resect a little bit from the torn piece and even kind of extend the tear a little bit, sometimes that does give you a little bit of freedom to reduce it and keep it there. So that would be my the only instance where I would attempt to to work with a tear that is a fragment that is not staying reduced.
All right, thanks, Dr. Lomas. We are going to now open the door and talk about meniscus transplants. So I'd like to introduce Dr. Eric Strauss, one of the members of our division of sports medicine here at NYU Langone, who's going to be talking about meniscus allograft transplantation, including indications, techniques, and results. So, Dr. Strauss.
Thanks, Mike, and thank you all for tuning in to our webinar. So as Mike introduced, we're going to talk about meniscal allograft transplantation. It's a topic I really enjoy. We've been doing an increasing frequency of meniscus transplantations with some very good outcomes. So I do have a couple of disclosures that are relevant. I work as a consultant for a few companies involved in meniscus transplantation, but the talk here is going to be evidence-based. So we're going to go over the significance and natural history of meniscus insufficiency, touch on the rationale for meniscal allograft transplantation, spend some more time on indications and patient selection, go over some of the surgical techniques, touch on the outcomes, and pull it all together in the next 15 or 20 minutes. So as was mentioned in the prior talks, we know that meniscal tears continue to be among the most common knee injuries that we see and treat. And compared to the 60s and 70s, when open, total, or subtotal meniscectomy was considered standard of care, as you've heard in the prior two talks, we're trying to minimize meniscectomy whenever possible and perform meniscal repairs whenever we think that healing can occur. However, it's not uncommon for us to be faced with a meniscus tear that, despite our best efforts, is going to result in significant excision of tissue. And we know that this is a big deal because there's a linear relationship between the amount of meniscus removed and the contact stresses seen in the affected compartment. As shown in this study out of Rush, there's, as we said, a linear relationship between that amount of meniscus excised and the contact stresses seen. And if you have a radial tear that extends to the capsule, it's just as if having no meniscus in there at all. We know since the days of Fairbanks that the meniscectomized knee basically has uniformly poor clinical results over time. And it's basically not a question of if they're going to get arthritis, it's a question of when. So we're often faced with this clinical dilemma that you see here. We have a young active patient who comes in with activity-related pain and swelling following a significant meniscectomy. We know from the intraoperative photos like you see here that the patient has intact articular cartilage in the affected compartment. And we also know that there's a poor natural history to the meniscectomized knee. So it raises the question of what do we do next? So while we can do an osteotomy to unload the affected compartment, an arthroplasty of any kind in a young active patient is going to be less ideal. So that raises the question of where meniscus allograft transplantation fits with respect to your treatment armamentarium. So the rationale for meniscus transplantation started showing up in the mid-1990s with studies like this published in the Journal of Knee Surgery that showed that compared to the meniscectomized state, as you see in the center, in the setting of a meniscal allograft transplantation, there's a restoration of more normal contact stresses in the affected compartment. So here's kind of a laundry list of the current indications for meniscal allograft transplantation. So the patient should be relatively young with an age less than 50. They should have symptomatic meniscus insufficiency with compartment pain, which correlates to what we know from the intraoperative photos. Comorbidities such as cruciate insufficiency or associated malalignment need to be addressed either prior to or concurrent with your meniscus allograft transplantation. Ideally, the patient has normal appearing cartilage within the affected compartment with no more than a focal area of grade 3 changes. When you've indicated a patient for a meniscal allograft, the first step is you need to basically obtain a sized matched allograft. So you submit their MRI to the tissue bank, and they're going to use the Pollard technique to match the meniscus allograft with respect to both A to P and medial lateral dimensions. So here's an example of the offer form from the tissue bank for one of my patients looking for a lateral meniscus on the right side. And you can see that they basically outline the size of the patient and the size of the donor. You want to be within 5 to 10% with respect to both dimensions in order to have perfect contact stresses in that compartment once you're finished. So with respect to surgical technique, the first thing to discuss is patient positioning. You need to have access to both the posteromedial and posterolateral aspect of the knee to basically catch your sutures from the repair portion of the procedure. We're going to start with a diagnostic arthroscopy to confirm the meniscal insufficiency and the status of the articular surfaces. Then we're going to do a meniscal debridement, and if Jacob can show the video here, we want to leave about a 1 to 2 millimeter peripheral rim so you have something to suture to, but you don't want to leave too much meniscus that's going to basically keep your graft too far into the affected compartment. So we're going to basically bite back to that 1 to 2 millimeter peripheral rim, shave, get our bleeding surface, and have something to repair to. All right, back to the slide deck, please. Excellent. So with respect to the approach, there's two main ways to basically implant a meniscal allograft. One is a bone bridge technique, and one is a double bone plug technique. For all of my lateral meniscus transplantations and some of my medial meniscus transplantations, especially when they're isolated, I prefer this bone bridge or bridge and slot technique like you see here in the image on the right. The reason I feel like this is superior, and this has been borne out in a lot of literature, is that when you have the bone bridge in place, it maintains a normal anatomic relationship between the anterior and posterior horns of the allograft, as you see here. When you've prepared the slot, as you see here, you have a final rectangular oriented slot that's 8 millimeters in width and 1 centimeter in depth. And that's going to easily allow the passage of your 7 millimeter bone bridge that you're going to get in the preparation that you see in this next slide. So when you get an allograft, it's the meniscus attached to the tibial plateau. We're going to utilize a lot of measurements to make sure that we have that 7 millimeter wide bridge that fits smoothly within this sizer, as you see here in the image on the bottom. And we have it about 1 centimeter deep. We're going to initially pass a shuttling suture at the junction of the posterior horn and body of that meniscus to facilitate seating of the meniscus once we get it into the prepared site. So once the meniscus is inserted, we're going to utilize a screw placed central to the bone bridge. This is typically a 7 by 23 millimeter bioabsorbable interference screw. Then we're going to perform our peripheral meniscal fixation, and this is vertical mattress sutures, either 2O, PDS, or Ethibond, through an open posterolateral or posteromedial approach. We'll often get a Henning retractor or a surgical spoon in there to protect the posterior neurovascular structures. And then as you see, Jacob, if you just want to run the video real quick, it's pretty much classic vertical mattress sutures using zone-specific cannulas like you see here. So we're going to work from posterior to anterior, and we're going to get nice fixation, 3 to 4 millimeters spaced out all across the meniscal allograft. And all the way posteriorly, to avoid injuring the posterior neurovascular structures, I like to put 1 to 2 all-inside devices, usually with one placed on the superior surface and one on the inferior surface of the meniscus. As you see here on the left, there's our finished product. So we're going to run these two videos, if you don't mind, Jacob. On the left is the final product, and on the right is our second look, which we had to go in actually for a tear of the other meniscus. And what I'm hoping that you guys see is that the meniscus looks well incorporated peripherally. It's stable, and if you didn't know it was a meniscal allograft, you couldn't tell that it wasn't the patient's native meniscus. All right, we'll go back to the slide deck and keep moving. Thank you. All right. More and more recently, for my medial meniscus transplantations, especially in the setting of a concomitant ACL reconstruction, I've converted to using a double bone plug technique. The benefit here is that you're avoiding the concomitant tibial tunnel from an ACL reconstruction. So what we've done here, as you see in the bottom left, is this is our prepared allograft with a 7 millimeter wide by 8 millimeter deep bone plug at both the posterior and anterior horns of that meniscal allograft. We're going to start by creating a posterior tunnel using a retrograde reamer. It's a blind tunnel, 8 millimeters wide and about 10 millimeters in depth. Well then, as you see in this image, we'll pass those sutures, seat the posterior bone plug. Then through the small arthrotomy, we're going to create a blind tunnel anteriorly for that anterior plug and similarly fix it on the tibia. Here's a short video just showing a double bone plug technique. So Jacob, if we can get that going. So here we're using a tibial aimer to find that posterior root location There's our retrograde reamer, 8 millimeters in diameter, drilled to a depth of 10 millimeters. We're going to pass a shuttling suture, as you see here, which is going to allow for seating of that posterior bone plug. Once that bone plug is in place and you're really going to get it seated in that posterior tunnel, we're going to proceed with our peripheral fixation, as we said, using zone-specific cannulas in vertical mattress fashion. We're going to put sutures both on the superior and inferior surfaces of that meniscal allograft to give a balanced repair. And in the end, we've got a nicely fixed allograft filling that compartment. Back to the slides, please. So post-operatively, there's really no consensus on the appropriate protocol following a meniscus allograft transplantation. But what is clear is that initially you have to protect the graft. So at NYU Langone, our typical protocol is listed here. We go toe-touch weight bearing for 2 weeks, followed by weight bearing that's tolerated initially with crutches. The patients are in a hinged knee brace for 6 weeks, initially 0 to 90 degrees, and then we're going to basically open it up and get rid of the brace at around 2 months post-operatively. We don't allow weight bearing at flexion angles greater than 90 degrees for 8 weeks to really prevent too much shear stress on that allograft meniscus. We allow the patients to get on the stationary bike at 2 months. We allow them to on the treadmill for jogging at 3 months. Depending on their return of range of motion and quad strength, they're back on the playing field at 6 to 9 months. And that's been our experience for the last 6 or 7 years here. So if you look at the clinical outcomes in the literature, there have been an increasing number of studies published on the outcomes following meniscal allograft transplantation. But as you see here on the table, most are relatively small with respect to patient numbers, and there's a very large variability with respect to the results reported. And some of this variability is related to the preservation techniques used for the allografts and the surgical techniques utilized. If you look at the more recent articles, the outcomes are quite good with high satisfaction rates and as I'm going to show you, a pretty good return to sport. If you look here at Elatar's meta-analysis that includes 44 separate trials published in 2011, they had more than 1,000 grafts and 1,000 patients and followed for a mean of 4.5 years. And as you can see, there were significant improvements with respect to VAS pain scores and the Leicht-Holm functional scores. Almost 90% of the patients in this meta-analysis were satisfied with their outcome. And that led the authors to conclude, as you see here in yellow, that meniscal allograft transplantation can be considered safe and reliable for the treatment of refractory post-meniscectomy symptoms in the right patient. So what about that return to sport? So if you look at this study out of Rush with Brian Cole, they had 13 patients ranging from high school to professional athletics, and a little more than 3 years of follow-up, more than 3/4 of patients returned to their desired level of play. So to kind of pull it all together, what I hopefully got across is that symptomatic meniscal insufficiency in a young patient is a relatively common scenario and can be a difficult problem to tackle. We know that if left alone, it has a poor natural history with a pretty reliable path to symptomatic osteoarthritis. What hopefully I demonstrated was that for the appropriately indicated patient, a meniscus allograft transplantation can relieve pain and improve function, and it does so by restoring more normal load distribution in the affected compartment. Whether or not an allograft slows the development or progression of arthritis is yet to be fully proven, but as our outcome studies become more midterm and long-term, we should have the answer to that question relatively soon. So as you saw, many techniques are available. What I think is important is that whichever way you go, you want to maintain bony attachments. There are studies out of Europe where they're just implanting a soft tissue meniscus, and I don't think that's going to work. I like the bone bridge technique, especially laterally, because it maintains that anatomic relationship with the horns. The procedure is technically demanding and has a lot of steps, but once you get the hang of it, you can do a meniscal allograft transplantation in under 2 hours pretty reliably. The optimal postoperative management and rehab protocol is still uncertain, but what I hopefully got across is that the key is early protection of that allograft. So I appreciate your time, and I'm happy to answer any questions that you guys have on meniscal allograft transplantations.
All right, excellent talk, Eric. So we have completed the 3 initial talks, and now we're going to move on to the case presentation and question portion of this webinar. So I'm going to turn this over to Mehul to talk about the first 2 cases. Mehul.
All right. Again, excellent talk, guys. Let's move on to some cases. And again, any audience members who have questions, please put it in, and we'll try to get to them out when we can. All right. So moving on to our first case. Case 1 is a 22-year-old male with an acute onset of left knee pain and swelling and inability to achieve full extension. He had a twisting injury during martial arts a day prior to presentation where he felt a pop, noticed swelling, and his knee felt locked. He was unable to bear weight on, and he had a large fusion on exam, and he had a tenderness palpation over the medial joint line. Here are the MRIs, and as we can see, both on the coronal and the sagittal images, that there is a displaced meniscal fragment or a displaced bucket handle tear of the medial meniscus. So these are the arthroscopic findings, in which you can see clearly, again, in the top left-hand corner, that the medial meniscus is displaced into the notch and right off the capsule. So, for our first audience response, Jacob, if you can bring up the polling for the first polling question. For this injury, would you A, perform a medial meniscus repair using an all-inside technique? B, do a medial meniscus repair using an inside-out technique? C, using an outside-in technique? Or D, do a partial medial meniscectomy, or medial meniscectomy in this case. So letting our responses come in. Basically, 77% of you would use an all-inside meniscus repair technique. Okay, Jacob, you can bring that back down. Go back to the slide deck. Let me ask our panel, Eric, what would you do in this situation?
I think this is a young, active patient with a acute displaced peripheral tear of that meniscus. This is begging for a repair. For these, I tend to like the old-fashioned inside-out technique, using zone-specific cannulas and the 2-0 Ethibond sutures, like you guys saw in the allograft presentation. I think it's reliable, it's proven, and I think it's going to give this patient the best chance at healing that meniscus and getting back to the activities they enjoy. So I'm going to pick, I guess the results say number 1, but I'm going to pick choice 2, perform a medial meniscal repair using an inside-out technique.
Okay. So also, Guillaume, in this situation, would you ever consider pie crusting the MCL? Do you think this is a good indication for your pie crusting? And again, how do you do it?
Yeah, I think so, and I've even done them in ACL reconstruction cases, so where the MCL was otherwise preserved. So Laith talked about doing it at the tibia. I do it at the femur. In both cases, you really can feel the sort of thick part of the MCL, and it feels again, I'll say it again, it just feels a little crunchy. And if you're not in something crunchy, you're not in the right spot. But once you get in there, it's pretty clear. And 1 or 2 stabs with the needle at that point, with a good valgus stress, will just open up the compartment just as much as you need. And at that point, you can, you've got to be able to visualize the tear in order to do an adequate, technically sound repair, using either the zone-specific cannulas or an all-inside device. So if I can't actually see the tear, I have not exposed that compartment enough.
Okay. And Mike, would you do anything such as a microfracture or PRP and stem cells in this isolated bucket handle tear?
I probably wouldn't inject PRP or stem cells. I don't think we really have the data to support that yet, especially with some of the studies that have been presented in this webinar. I am microfracturing the notch. There's, again, little data, except for the one study that was presented, but I think by making those marrow channels, you can hopefully speed up the healing, or at least make it a little bit more reliable. What about you, Mehul?
No, I think in this case, the only thing that I would do in this situation is just microfracture or marrow vent to bring in the pluripotent stem cells. So during this surgery. It does look like they were preparing the meniscal bed off the capsule first with the shaver and then the rasp, and then, as Eric said, using an inside-out technique. Now, Eric, quick question. In the back, sometimes it's really hard to get to the very back, especially with these cannulas. Do you use a hybrid technique? Do you put one or two all-inside anchors in the back in combination with your inside-out technique?
Great question. Often that is what I'll do, similar to what we're doing with the allograft. For the most posterior aspect, I'll use one of the all-inside devices. Another trick, if I want to get just additional vertical mattress sutures in, what I'll do is make an accessory portal. I don't even mind going transpatellar tendon just to get a better angle at that posterior horn. And with that Henning retractor or surgical spoon in there, it's still safe. You still capture your needle, but you're still getting the benefit of that old school vertical mattress repair.
Oh, that's a great technique.
Mehul, can I just add one thing?
Yes.
And because Eric, I've seen you do this, and I think it's a point worth mentioning. You don't, all the vertical mattress sutures don't have to go on the superior aspect of the meniscus, because sometimes you get a really nice repair if you alternate, putting some on the superior aspect and then going underneath and putting vertical mattress on the inferior aspect of the meniscus, and you really kind of paste it against the capsule nicely in that way.
Great point.
The only thing is going underneath for me. I find it difficult to go vertical below. So I typically go horizontal below and vertical up top, and it seems to work better in my hands. But yes, also especially when you go up top and the meniscus sort of flips up on you, those are great to go below. So yes, and this case was marrow-vented as well. And go ahead and play this video. This is the guy with the black hair, Jacob. If you just play that video shortly, you see he's back to martial arts, no complaints, 2.5 years post-op. All right, so let's go on to the next.
And Mehul, what we realized, thankfully it healed, because if it didn't heal, we would have been in pretty big trouble with this guy.
Exactly. Good job. All right. So let's go on to case number 2. So case number 2 is a 20-year-old female college basketball player with 4 months history of lateral-sided right knee pain, swelling mechanical symptoms after a twisting injury. She was unresponsive to non-operative management, including corticosteroid injections, hyaluronic acid, and PT. She's not playing at her usual level due to the symptoms, and she's tended a patient directly over the lateral joint line, which is also causing an effusion. So on MRI, you can see in the lateral meniscus, there's significant horizontal cleavage tearing of the posterior horn and body of the lateral meniscus. So again, in the arthroscopic finding, right at the junction of the posterior horn and body, you see this horizontal cleavage tear. The edges were debrided, and now I guess the true question is, what would you do at this point? For our audience, again, Jacob, if you can bring up the polling question. Would you debride the tear and leave it alone, perform a partial lateral mastectomy, improving the inferior leaflet, perform a partial lateral mastectomy, removing the superior leaflet, or perform a lateral meniscal repair? Okay, well, it seems that the majority, or 80% of us, would perform a lateral meniscus repair. And I guess the true question at this point is, how would they perform it, right? Okay, Jacob, you can go back to the deck. So for our panel, Dr. Jazrawi, what would you do in this situation?
So, historically, these would be very challenging to repair. I think the inside fixator devices, the fast fix, very challenging to get these cleavages closed in sort of an anatomic pattern. So the device that, a device that can pass a bail stitch, and one of the participants asked that question, it's the Ceterix device, where a stitch could basically, in one bite, grab both the inferior leaflet and superior leaflet. Then you just have to tie an arthroscopic knot with the 2-0 suture. And I think that's really one of the only ways that this could be done. Inside-out repairs where you make an incision laterally, again, having to make the incision, again, not challenging, but you need an extra pair of hands potentially, can also be done. But I think in this case with this newer device where you can pass this bail stitch, it's a great way to fix this tear.
Now, would this change if this was an older individual, if this was a 50-plus individual with, the straightforward horizontal cleavage tear? Would you do the same thing, or would you do something differently?
Yeah, I think if the knee looked like that, like it was shown there, without any degenerative changes in a pristine cartilage, and the patient is, fairly active, I think it's still one where I would fix. That area where the tear is, that's right by that popliteus hiatus. There's not much meniscus tissue back there. As you start to debride that inferior leaf, that superior leaf, without an attachment to the capsule back there because of that popliteus recess, is really very wimpy. So in these cases, specifically with that location, I have no issues with potentially, with fixing this in a 50-year-old patient.
Okay. So if this patient was in season, how would you manage it? Eric, why don't we throw this to you? Would you do surgery now in this person as an in-season athlete? Would you give him another cortisone shot or anything else, a PRP shot? And when you do surgery, when would you let this person back to play?
So that's a great question. I would do my very best to do not perform surgery in season. Try, present every option possible to get them through the season and then treat her subsequent to it. That could be another corticosteroid injection. We'd also discuss the potential for PRP. If everything we've tried doesn't work and she's not playing at the level that she needs and wants to, then we would bite the bullet and do procedure. With respect to return to play, with these cleavage tears, I usually give it a little more time, so we're looking at 3 to 4 months. And often I'll get a follow-up MRI to see if there's evidence of healing or persistence of the tear before we fully let them back to unrestricted play.
That's a great idea. So again, like both of you wanted to do, a bail stitch was placed with the Soterix device, 3 stitches in the lateral meniscus, performing a nice secure repair. And again, the Maraventi technique was used to stir up healing. Repeat MRI 6 months later showed excellent healing of the repair, and the patient was back to sport 1 year post-op with only mild patellar tendonitis, but no lateral joint line pain or swelling. So for the following case, I'm going to hand it over to my colleague, Mike.
All right, so we're going to move into our third case. This is a 17-year-old male cross-country athlete, posterior medial right knee pain and swelling after a mild twisting event during practice. He had very little difficulty ambulating, but he was unable to run. On exam, he had tendinous palpation directly over the posterior medial joint line with a trace of fusion. So here you can see his MRI. You got some T2 weighted cuts, 2 coronal cuts, and 2 sagittal cuts. And you can see what looks like it'd be a little bit of a ghost sign there, especially on the coronal. And you can see on the sagittal as well. And this might be typical of a meniscus root injury. So we move into our arthroscopic findings. And what we see here in the picture on the top left, it does appear that you might be fooled thinking that meniscus is completely intact if you don't get a really good view of this arthroscopically. So you kind of have to get around the corner a little bit, utilize all your arthroscopic tools to really get a good assessment of that posterior root. But in this particular case, it certainly was torn. It was avulsed directly off of the tibia posteriorly. So let's get the audience response for this, and we can bring up the poll. So for this injury, we're going to 1, debride the tear site and leave it alone after that. Number 2, perform a root repair using a transtibial tunnel approach. Number 3, perform a root repair using a suture anchor. Number 4, leave it alone. So you can really see here, overwhelmingly, the great majority of everybody decided to do a root repair using a transtibial tunnel approach. And we can go to the next slide or get rid of the poll. I'd like to discuss this with the panel. So I'm going to open this up first to Guillaume to see what he would do.
Thanks, Mike. I would, in a case like this, obviously you want to probe it and make sure, assess the stability. But if it's unstable, I would do the root repair with, I use the transtibial tunnel approach.
What kind of stitches are you placing, Eric?
I use that like luggage tag suture. And one of the things that I think that one of our common errors with this is that I think a lot of times we make that posterior tunnel too medial. It ends up being more in the compartment than we want. So one of the things you may want to have in the room if you're going to perform a root repair is a 70-degree scope, which is going to enable you to really see around that corner and make sure that you're truly at the posterior root attachment.
Leif, any role in taking down the tibial spine at all or doing a reverse notchplasty to get better visualization here?
Yeah, I think it depends on the patient. Certainly, in almost all these cases, I'm doing an MCL pie crusting to really open up there. I think it's critical, like Eric said, you got to be able to see. And if you think you're posterior enough, you're probably not. So I think doing that, doing the reverse notchplasty. And then the other thing, Mike, I think is important is that looking at different types of techniques in terms of doing this and seeing what you're comfortable with. There's certainly a role for putting the knee, in the notch, Gilchrist approach, making a posterior medial portal, and attacking it potentially with a suture anchor technique. It's a little more challenging. The angle's more difficult, and the suture passing is more challenging compared to the transtibial technique. But there are different types of implants where you can use a push lock type of device where you pass some type of tape through the meniscus at that level, and then a knotless type of repair that can be done there through posterior medial approach. I think going to the lab, practicing it, and seeing what works in your hands is something that I would encourage everyone to do who's going to start venturing into fixing these roots.
All right,
Mike, really, if you don't mind, the other aspect of taking down the spine, like you ask, is that if you're going to do the transtibial approach and use an ACL drill guide, by taking down the spine, it lets you flatten out the guide, and it's much easier to get the pin where you want if that spine's gone than if you're trying to negotiate over it.
All right, real quick, post-operative rehab, do you limit their flexion, and then when do you allow them to return to sports?
Are you asking me?
Yeah.
So basically, it's a very similar approach to the that we discussed for the allograft. So basically, they're non-weight bearing, but they're non-weight bearing for a slightly longer period of time. I usually keep them non-weight bearing for 4 weeks. In that hinge knee brace, I don't let them flex past 90 for the first 2 weeks of weight bearing, so from the 4 to 6 week mark. I'm similarly going to get an MRI for follow-up before I release them back to athletics and base it on their return of range of motion, strength, and whether or not they have any symptoms in that compartment.
All right, so we only have 5 minutes left, so I'm going to jump ahead to the fifth case. The fourth one is a little bit less interesting, but for this, we did perform a meniscus root repair using the transtibial technique. We've got 2 racking sutures here in place, and then dunked it through a transtibial approach. This is a post-operative MRI at 6 months. You can see that on the bottom 2, there's elimination of the ghost sign. This patient ultimately did well. So we're going to move ahead to the fifth case. It's a little bit more interesting. So this is a 19-year-old male college baseball pitcher with left knee pain, swelling, and mechanical symptoms. In 2007, he had a bucket handle lateral meniscus tear, which was treated with a subtotal partial lateral meniscectomy. He did well until about 3 weeks prior when he twisted his knee again, felt his knee pop, and had an effusion, was unable to bear weight. This was his imaging, which shows on the lateral aspect of his knee, he's got a significant osteochondral lesion, looks quite large in size. This is his initial arthroscopic finding. You can see there's a very large loose osteochondral piece, which actually came out in several pieces, and then you can see that lateral compartment's pretty much bare and devoid of any kind of meniscal tissue. So for the audience response, let's again bring up that poll. Jacob? All right.
No.
Well, this isn't the right one, but the options are essentially, number one, perform an osteochondral allograft now and then a lateral meniscus transplant later. Number two is perform a meniscus allograft now and a lateral femoral condyle osteochondral implantation later. Number three is perform a combined procedure now. And number four is leave it alone and see how he does after just a debridement. We'll give him another few seconds for the audience to chime in here. But you can go ahead and close that poll now, but it really looks like the majority of people would perform a combined procedure here. So let's talk to our panel now, and we can start with Laith in terms of his assessment of this.
Sorry, I was just taking it off the mute button. So for the approach it certainly needs to be addressed. I think some people get concerned about the time of surgery required to address both the osteochondral allograft and the meniscus transplant at the same time. And I don't think it's wrong, to stage this. So I think that's certainly if you're venturing into doing these type of surgeries, don't be afraid to stage it. It's okay. My preference is to do both at the same time in terms of my approach. In terms of the order of business for this, my approach would be first getting the meniscus in, because you want to keep the knee as closed as possible while you're doing this to keep the fluid going in. After the meniscus goes in, you can pass the sutures, don't tie them yet, then do the arthrotomy or extend your arthrotomy, get the allograft in, then you can tie the rest of your sutures as part of the transplant.
Eric, would you use a bridge and slot here or bone plugs?
This is a lateral. This is a lateral case, so this for me is a bridge and slot approach every time.
You agree? Yes or no?
Yes.
All right. Seems like everybody's in agreement. So essentially, this is what we did. We did a combined lateral meniscus allograft transplant with a bridge and slot technique, as well as an open osteochondral allograft transplantation. You can see on the top left, inside-out sutures being placed. And ultimately, these are open pictures in the bottom three showing a osteochondral allograft, which is nice and flush to the lateral femoral condyle. This is the patient's second look at 3 months. You can see that the osteochondral allograft is implemented very well. The reason that we went back in was for a lysis of adhesions and a manipulation. But on second look and inspection closely of that meniscus tissue, it looks like it's integrating very nicely. Obviously, we've gotten full flexion on the table. You can see from the picture on the bottom right. And ultimately, this patient has gone on to do very well, back to baseball at 1 year. A little bit of post-game soreness, but no swelling, no mechanical symptoms, and he had a pretty good ERA last year. So that pretty much concludes the case presentation portion of this. It's 9:30, so we're done with this webinar. We'd like to thank everybody for coming and participating in this. We hope that we have been able to answer a lot of your questions for a somewhat challenging problem, especially for our young patient population who are very active with this relatively avascular type tissue. So for myself, I'd like to thank everybody. I'd like to thank Dr. Shah for co-moderating this as well, Dr. Jazraoui, Dr. Strauss, and Dr. Gonzalez-Lomas on a very nice job. So thanks to everybody, and thanks to Blue Sky for putting this together.
All right. Well, perfect. Thank you very much to all of our presenters today. On behalf of NYU School of Medicine, I would like to thank you for your participation in today's event. You will now be redirected to a course page. Please take a moment to complete the appropriate course evaluation to claim your certificate. This does conclude today's program. Thank you, and have a great day.